Now, welcome to the tiebreaker round of the Ultrasound Games at the Stadium of Light in EUSEM, Lisbon, 2021. Boy, do we have a game for you now. So, 2 teams left, and you are going to make the decider on who is going to go through, whether it be Team Europe or Team Rest of the World. For Team Europe, we have Dr. Calum from the Mater ED in Dublin, and we have Dr. Rachel Gilmore from Connolly Hospital, also in Dublin, and they're going to take on the team from the Southern Hemisphere, consisting of Dr. Justin Bowra, the David Attenborough of Ultrasound, who hails from North Shore ED in Sydney, and myself, Nicolas Lim, from Woodlands Health Campus in the Republic of Singapore.
Hello everyone, my name's Calum. I'm an emergency medicine SPR in the Mater Hospital in Dublin, and today I'll be doing a very micro teach on point-of-care ultrasound for small bowel obstruction. So you have a middle-aged man come into the hospital and he's complaining of abdominal pain and vomiting for the last 3 days. Clinically unremarkable exam, abdomen's not particularly distended, vitals are normal, but you put a probe on and you see this big dilated loop of bowel over the abdomen, loop of small bowel with dysfunctional peristalsis. So your diagnosis is made, small bowel obstruction. Measure out the dilation, 3.2 centimeters. Get him a CT abdo-pelvis, confirms high-grade small bowel obstruction with a transition point, and he goes for theatre. So what are you looking for in ultrasound? Well, dilation of small bowel loops greater than 2.5 centimeters, altered intestinal peristalsis, increased thickness of the bowel wall, or intraperitoneal free fluid accumulation. And dilated loops are easy enough to measure, so I would use the curvilinear probe, have a look in all quadrants of the bowel. If you see bowel loops by itself, that's a kind of concerning sign, but certainly if they're dilated more than 2.5 centimeters. To and fro peristalsis, or poo and fro peristalsis as some people call it, and I love the name of that sign, is what it says on the tin. You see the fecal matter going one direction and then you see it going the other direction, and that shouldn't be the case. Obviously it should be a one-way direction in the bowel. A very concerning kind of late sign is bowel wall edema or intraperitoneal free fluid, as you can see here, so that implies a degree of ischemia. Why bother with ultrasound? Well, it's certainly better than X-ray, which is still used in some places. X-ray has a poor sensitivity. As you can see here, the same patients can have a negative X-ray and a very positive CT. So ultrasound has been shown to have a high sensitivity and specificity, even in relatively untrained hands, although the sensitivity and specificity will improve the more experienced you are with the use of ultrasound. And making a diagnosis at the patient's bedside during your primary assessment means that you can rapidly progress to CT and definitive care, reducing unnecessary time delays and reducing misdiagnoses. And it's easy to learn. So hope you enjoyed that, and get out and scan some bellies. Thanks.
Hi, my name is Rachel Gilmore and I'm a consultant in emergency medicine in Dublin. And I want to do my sonobite on the patient who presents with undifferentiated shortness of breath to the emergency department. These are very common presentations to the emergency department. Patients often have multiple comorbidities. They often have a history of both CCF and COPD and present with shortness of breath. And clinically, it's very difficult to differentiate the underlying condition. Chest x-rays are often non-diagnostic, and blood tests take a while to come back. And the treatment of these patients depends on us knowing what's causing the shortness of breath and differs markedly whether it's pulmonary or cardiac cause. So how can we do this better? We can do it better by doing ultrasound early at the bedside. This paper in 2016 by Arun Najev describes a triple scan approach to initial assessment, which improved diagnostic accuracy in these patients from 50 to 80% and had a sensitivity for acute decompensated heart failure of 100%. So how do we do this? We do this by first of all doing a parasternal long axis of the heart, looking to see, does it look normal or is it very reduced ejection fraction like on the right? We then look at the lungs. I like to look at the lung bases, see if there's pleural effusions. If there's bilateral pleural effusions, it's very suggestive for acute decompensated heart failure. And you can also look at B lines by moving your probe further up in the chest. And then I look at the IVC. Is the IVC really big, plethoric, not changing with respiration, or is it very small and compressed and would make you think of another cause of shortness of breath? So that's it for my Sonobite. Do an ultrasound early and determine what's actually causing the shortness of breath and start appropriate treatment early. Thank you.
Hello, I'm Justin Bowra, and I work at Royal North Shore Hospital in Sydney, Australia. I don't know about you, but there's something weird I notice when I walk into the resus room these days. My junior doctor's there, slaving over a sick, breathless patient, and I ask them what's going on, and they say, look, they're not sure if it's pneumonia or pulmonary edema, but this patient is really breathless. And they've scanned the heart, they've started non-invasive ventilation, the chest x-ray is equivocal, and they're waiting on the BNP. And they'd really like to show me their heart images. They were hard to get, but they managed to get a glimpse of the heart somewhere behind the lungs, and it was tricky to interpret, but they're pretty sure it's beating. So, there's a long pause. And I ask what their lung ultrasound showed. And they didn't have time. Or they forgot. And this is my favourite. They were too busy scanning the heart. So in other words, I was too busy to scan the organ that's easy to scan, the one that mattered most in this case, and the one that gives the fastest answers. So I say, or at least I think to myself, what the f***? What's this bullshit love affair with cardiac scanning? The ridiculous glamour that the heart exerts on critical care doctors. The heart is small, weird, complicated, and hard to scan, especially in a patient who's sitting up, puffing like Billy-O. And the lungs are large, easy to scan, and fast. They give you the answer in about 30 seconds flat in some cases. Better still, if the lungs are dry, no B-lines, and the IVC is skinny and collapsing, you don't need to scan the heart at all. Let's just say that again. If the lungs are dry, the left ventricle is okay, and if the IVC is skinny, the right ventricle is okay. And that means you don't need to scan the heart in this patient because the heart is not the problem. And this applies to shocked patients as well as breathless patients. So for God's sake, guys, whether you're doing a rush or an ACEs or a blue or whatever protocol you happen to use in a shocked or a breathless patient, please start with the lungs, not the heart. Because you might love scanning the heart, but the heart will not love you back.
Hi all, my name is Nicolas Lim. I am an EM and ICU consultant based out of Singapore. I am going to talk to you about the aorta. The aorta is going to f you up. Aortic imaging is one of the most important techniques to learn when you first pick up point-of-care ultrasound. Oftentimes, trainees and colleagues come to me with a big frowny face, expressing great difficulty with imaging the aorta. The reality of the situation is that you are taught to scan the aorta wrong. You are taught to start from the epigastrium. When you invariably scan, you get this perfect view where you can even see the celiac plexus. When you go to scan a real-life patient, this is oftentimes what you see. The reality of the situation is that adipose tissue, food, body hair, and bile gas all get in the way of ultrasound. Have a look at this CT slice. You can see that the aorta comes really close to the anterior abdominal wall. It follows the lumbar lordosis. So why don't we scan lower down? Why don't we start scanning from the belly button? See here? This is the vertebral body and posterior acoustic shadowing. This is really noticeable even in large patients. The aorta is very closely associated with this. Look how anterior the aorta is. Look how clearly you can visualize this. Let's recap. Don't be a master aortic scanning. Hashtag start from the belly button. Start lower down. Start at the bifurcation of the aorta. It makes your life so much easier. Look for the vertebral body first. The aorta can only be closely associated with it. Don't let the aorta you up.